Very often, the attic cholecystoma extends to the mastoid antrum as indicated here by purple arrow. While addressing such condition through transcanal endoscopic procedure, we need to extend our dissection towards the mastoid antrum. Dear viewers, this video would demonstrate the practice of transcanal endoscopic mastoid dissection on cadaver to gain necessary skills and knowledge before applying such procedure on living patient. This is an inside-out technique using 0-degree endoscope. The surgeon is in sitting position, facing the monitor and the temporal bone, and holding the endoscope with camera head by the non-dominant hand while keeping the dominant hand for the necessary instrumentations. In our setup, we place a fresh cadaveric temporal bone on a bone holder attached with a table in such a way that in case of right temporal bone, the tip of mastoid will face the right hand of the surgeon, and vice versa. For the purpose of optimal endoscopy and easy instrumentations, both the right and left hands need to be adjusted while dissecting different parts of the mastoid. In the following pictures, such adjustment of hands will be shown separately for right and left temporal bones. Left and right hands are marked respectively with letter L and R. To expose the posterior canal wall, two inferior base flaps, one is tympanomeatal and another is meatal skin flap, as marked here by red lines, are needed to be elevated. During elevation of flaps, we would see that the skin is tightly adherent along the tympanomastoid suture. After elevation of flaps, here we can identify the tympanomastoid suture, malleus, incus, and the notch of Rivinus. A retrograde dissection of posterior canal wall, proceeding few millimeter above the tympanomastoid suture, as indicated here by arrow, would safely land us to the anterior part of the mastoid antrum. Since going below the suture line has the risk of injuring the hidden mastoid segment of facial nerve and the lateral semicircular canal. On the other hand, going straight up has the risk of injuring the roof of the mastoid and attic. After exposure of the posterior part of attic, we can see here the short process and the body of incus. Gradually, the dissection progresses posterolaterally over the tympanomastoid suture line. After this initial exploratory atticoantrostomy, we can identify the lateral semicircular canal and anterior part of the mastoid antrum. Further, posterolateral and inferior progression of the dissection would expose the entire mastoid antrum along with periantral cells. In this exposed mastoid antrum, this is the medial wall of adductus ad antrum. Dissecting here will expose the superior semicircular canal. This is the roof area of mastoid antrum. Dissecting here will expose the tegmen mastoidium. This is the lateral cortical wall of mastoid. This is the area over sinus plate. Dissecting here will expose the sinodural angle and the part of sinus plate. Dissecting this area will expose the posterior wall of the mastoid antrum and later endolimphatic sac. Dissecting this area from above to downward direction will expose the mastoid tip. Dissecting this area from lateral to medial direction will first expose the mastoid segment of facial nerve and then the posterior semicircular canal. Near the roof of mastoid antrum, we can see the corner septum or the petrosquamous lamina, separating the medial petrosal tegmen from the lateral squamous tegmen. The periantral cells near the roof, as indicated by the arrows, need to be dissected out in order to expose the tegmen mastoidium. Finally, after lowering down the corner septum, we can now see the tegmen mastoidium. Dissecting the periantral cells near the most posterolateral aspect of this exposed mastoid antrum, as indicated by arrows, would expose the sinodural angle and the sinus plate. Now we can see the exposed sinodural angle and the sinus plate. The dissection towards the inferior lateral aspect of the exposed mastoid antrum, as indicated by arrows, would lead us to the mastoid tip. In this picture, we can observe and compare the depth of exposed mastoid antrum with the floor level of the external auditory canal. Dissecting the retrofacial cells along a vertical plane running from the level of fossa inquitis towards the mastoid tip would gradually expose the mastoid segment of facial nerve. Here we can see the early exposed fallopian canal of the mastoid segment of facial nerve. Further dissection would expose the sheath covering the nerve. After opening this sheath, the nerve fibers would be exposed. This picture shows anatomical relation between the mastoid segment of facial nerve and the posterior canal wall. Dissecting the perilabyrinthine cells in the area medial to the mastoid segment of facial nerve and inferior to the lateral semicircular canal, as indicated here by arrow, would excavate the dome of posterior semicircular canal. Here we can see the exposed dome of posterior semicircular canal and its relation with the mastoid segment of facial nerve. This is the area of Adidas ad antrum, where its floor is formed by the readily exposed dome of lateral semicircular canal, and its medial wall is closely related with the superior semicircular canal. Dissecting the medial wall of Adidas ad antrum exposes the lumen of superior semicircular canal. After exposing the lumens of other two semicircular canals, here we can observe the anatomical arrangement of these three semicircular canals. This is the skeletonized posterior wall of the mastoid antrum in between the posterior semicircular canal and the sigmoid sinus. The Donaldson's line, as indicated here by the red line, passes along the long axis of the lateral semicircular canal and bisects the posterior semicircular canal. Then it goes on the posterior wall of the mastoid antrum towards the sigmoid sinus. Dissecting the area below the Donaldson's line and near the sigmoid sinus, as indicated here by the arrow, would expose the endolymphatic sac. After such dissection, here we can see the exposed endolymphatic sac. In this discussion, it has been evident that through transcanal route under endoscopic guidance, the entire mastoid antrum and the confined structures surrounding it could be successfully explored. This finding would serve two purposes. First, this would help the surgeon to get acquainted with the locations of these important structures under endoscopic view. Second, this gives impression that if mastoid antral cholesteatoma involves any one of these vital structures, these could be surgically encountered through transcanal route under endoscopic guidance.